Mathinva agus Falcha, good morning and welcome. It's lovely to see you all this morning for this public board meeting of NHS Highland in the month of May. So welcome to all the board members and a particular welcome to members of the public and press who have joined us virtually to observe the meeting today. Just a bit of housekeeping, you will see that the meeting is being recorded, and that's so that we can pop it up on our website later on for people to watch back. The usual sort of Teams etiquette, it's lovely if people can keep their cameras on and then I can see your beautiful faces, but obviously if you're having issues with your connectivity and you need to switch it off, that's fine. I would like to ask everybody to stay on mute unless you are asking your questions or making contributions, just to reduce the background noise for the call. We don't use the chat in this meeting, so if you would like to come in with a question or a comment, if you could use the hands up function, and then we will come to you in due course. I'll be keeping an eye on the hands, and Ruth and Nathan will be, I'm sure, keeping me right if I miss anybody as well. So before we start this morning, I would like to take this opportunity to officially welcome Fiona Davies, our new Chief Executive, to her first public board meeting. So obviously, many of us, or all of us, know Fiona very well. She's had a very long career in the NHS, and we know her through her previous role as the Chief Officer of the Argyll and Bute Health and Social Care Partnership. And indeed, Fiona's held senior roles both in Argyll and Bute, but also in the Highland Partnership area as well. Fiona, as we all know, is a strong champion of partnership working and delivering safe, effective care in our rural and island areas. And indeed, as a resident of the board, it's something she knows and cares about well. I've had the opportunity to work with Fiona for many years in Argyll and Bute when I was chair and vice chair of the IGB. So I'm really, really pleased to officially welcome Fiona to her role and to her first public board meeting as our new chief executive. I'm sure you'll all extend that welcome as well. So if we move now on to the agenda, Ruth, do we have any apologies today? Oh, have I lost Ruth? Oh dear. Oh no, there she is.
I think we have lost her, but we
think we have lost Ruth. Okay, Nathan?
Yeah, sorry, we've got apologies from Emily Woolard, Elspeth Caithness and Philip McRae.
That's great, thank you very much. Okay, declarations of conflict of interest. Steve.
Hi Chair, good morning everybody. I consider making a declaration of interest in my capacity as Chief Executive of High Life Highland, but I've applied the objective test against the agenda and I don't think it's required. Thank you.
Thank you, Steve. And Alistair.
Yes, thank you and good morning. I also had considered making a declaration of interest in my capacity as a Highland councillor, but having examined the items on the agenda and my connection to them and applying the objective test, I feel I don't need to do so.
Thank you very much. Okay, I'm not seeing any other hands up, so we can move on. So item 1.3 on the agenda. This is the draft minute of our previous meeting, which was held on the 26th of March, and the associated action plan. So first of all, I'll take the minutes. Are members happy to confirm that that was an accurate reflection of our meeting? Great, thumbs up. So those minutes are approved. And if we then turn to, well, I'll just check, sorry, that was for accuracy. Does anybody have anything they wish to raise from the minutes before I go on to the action plan? No, okay, great. So if we move on to the action plan, now I don't know if we've got Ruth back with us. I'll just check to see if Ruth has managed to, lovely.
Yes,
Ruth, do you want to? Lovely. Do you want to just talk to the action plan and what's proposed with the action plan this time?
Sure, yes, thank you. Sorry about that. I do have connectivity challenges this morning, so I'll keep my camera off for the time being, if that's all right with you. The action tracker shows progress against several of the actions, and 3 of them are actually proposed for closure and 2 are currently still in progress. So I'll read from the top. Action number 17 relating to the IPQR executive summary, focusing on all health, care and prevention outcomes, is still in progress, and it'll be reviewed in line with the targets and trajectories being agreed as part of the ADP. Action 19 relating to revising the format of the corporate risk register to include pre and post mitigation scoring is still in progress, so that will come back to you at a later meeting. Action 20 has now been completed, and that was a request to update board members with information on our welfare advice and health partnership work. Similarly, Action 21, that's now been completed. A request for details was sent out to board members on third sector involvement in meetings of the Mental Health Delivery Group. And Action 23 relating to inclusion of references in standing financial instructions to commissioning of care homes and care at home is now included on today's agenda. So closure of that action will depend on the board's decision on that paper later on in this meeting. So thank you, Sarah.
Thanks, Ruth. So I suppose then if we take actions 20 and 21, which are proposed for closure, are members content that those 2 can be closed? Okay, great. So that's confirmed. So 2021 can be closed. 23 then, obviously that's proposed for closure, but we do have, as Ruth has said, we've got that item later on the agenda. So what I'm going to suggest we do is we agree to close it on the assumption that the item later on the agenda is taken as approved or agreed, but I can't remember what the instruction is. So we can instruct that. Can I just check, Ruth, for 17 and 19 at the top? I understand that they're still in progress, but just obviously we had those due dates for today, so we're going to need to adjust that because they are still ongoing. I don't know if we're proposing that for the next board meeting.
Well, I'm in your hands. It's certainly an opportunity to think of the revised date for those ones.
I can
Happy
see that
to
David
take your instruction. Yeah.
Yep. So David's got his hand up. So David, I'll bring you in.
Yeah, happy to take them forward to the next meeting. There have been some modifications made already, and so we'll look to try and close that for recommendation at the next meeting. We'll summarise that in our SBAR next time around.
Okay. So members happy then that with those first 2 on the plan, 17 and 19, we'll amend those due dates to the date of the next board meeting. Okay. Does anybody have anything else they wish to raise with regards to the action plan? No. Okay. And just generally, I've probably allowed enough opportunity, but just to check in, does anybody have any other matters arising? No. Lovely. Okay. So in that case, I will move us on to item number 2 on the agenda. And for the very first time, I shall hand over to Fiona to give us her Chief Executive's report. And you'll notice there's been a slight change. We have some written updates from Fiona, but Fiona also is going to talk to us about what else is going on. So I'll hand over to you now, Fiona.
Thank you, Chair, and thank you for your earlier comments. They're much appreciated. And thanks to all of you that have been in touch with me since coming into my role on the 1st of April. I've received a really warm welcome from within the organisation and indeed from many partner organisations across the whole area. As you can see from my report, I've already been out meeting groups in the community and have visited hospital services and community and primary care services in several districts and indeed in Regmore Hospital too. I've had a good number of meetings with Highland Council in regard of community health and social services and our wider partners within the Highland Community Planning Partnership. And before anybody mentions it, I'm heading to Argyll and Bute tomorrow, and so I can update on that visit in my next report. I've been contacted by staff across the organisation who heeded my offer in my first day video blog to get in touch. And this has covered a wide variety of topics. It's so useful for me to understand what's on people's minds especially when the challenges of delivering services are being felt on a continuous basis. Some of these communications have been suggestions for cost savings, and some have been challenges as to whether the right plans and responses are in place to meet our organisational responsibilities. But no matter the topic, my virtual door is open. In my report, I'd updated the board on my early engagement with the SOS NHS Sky Group on the 22nd of April, and the commitment myself and the chair made, having listened carefully to the frustrations of the group, to meet the recommendations of Sir Lewis Ritchie in 2018. After my report was prepared, an incident occurred in Portree on the 11th to the 12th of May that has brought considerable press and public attention on services at Portree Hospital. I am sorry that equipment that was requested to support our local emergency services and the festival medical team in responding to a member of the public was delayed. Every member of hospital staff did their duty that night, and some colleagues, both on and off duty, went above and beyond to help. I've met with the staff on shift that night and many of their colleagues in Portree to listen to their distress at what they felt was criticism directed at them. I thanked them for their contribution to meeting the health needs of the population of North Skye, and I'm grateful that it has been recognised that the morale of local staff, leaders and managers is essential to be maintained as we look to implement the recommendations of the review. Subsequent to the event, I was asked by Cabinet Secretary Neil Gray to provide a plan to assure completion of the recommendations, particularly in regard of urgent care access in Portree. I have been grateful that Sir Lewis Ritchie has made himself available to me to ensure that I am authentic to his intentions, and I would like to particularly note my thanks to him for his commitment to this process since 2018. The plan has now been submitted, and I will continue to engage with staff and local stakeholders to ensure that the actions are complete and ratified to the satisfaction of this board. I've engaged with local elected members and members of the Scottish Parliament to assure them of my commitment to complete the actions and to seek their support in assisting me in addressing the root causes of remote and rural delivery challenges, such as workforce supply and housing. These rural challenges are underpinning our financial challenge referenced in my report, costs largely driven by our reliance on agency, locum and other supplementary staff currently required to provide safe staffing levels within our services. As I mentioned in my report, work is progressing in delivering 3% efficiency savings. However, this leaves a substantial amount to achieve, and we will see further detail of that in our finance report later in the meeting. The last week has also seen the publication of the report regarding the infected blood inquiry. Our deepest sympathies are with the patients in NHS Highland and beyond who were infected by the use of blood products and their loved ones. This is a significant report with a number of recommendations that will apply to health boards and health organisations across the UK. NHS Highland is fully committed to engaging with the implementation group to make any outstanding improvements. While the number of patients treated with blood products in our area at the time covered by the report was small, the impact on individuals cannot be overestimated. In particular, I note poor communication with patients is reported, and this is something we must continue to strive to improve. It is important to recognise that modern safety standards are rigorous, and significant advancements in screening and testing protocols have been made since the events that have been the subject of this inquiry. All donated blood then undergoes thorough testing before being used for transfusions. Finally, I would like to draw the board's attention to the International Recruitment Pastoral Care Quality Award received by NHS Highland in recognition of the very high standard care we've offered overseas staff coming to work in the NHS Highland area. I am proud that the welcome and hospitality that this part of the world is so well known for has been offered to colleagues making a new life and home in our area. Through my Cascade brief, I've asked staff across the board area to reflect on what it means to welcome and how we can ensure that all staff coming to work in NHS Highland, whether international or from other parts of the UK or indeed from our own local area, can share in this warm introduction to the area for themselves and their families. I'll pause my comments there, Chair, and I'll take any questions on the content of the report. Thank you.
Thank you, Fiona, for that really thorough introduction. I think that's been really helpful for people to understand both what you've been up to and in your first few weeks in post, but also what's going on more widely in the organisation. So I'm happy if anybody would like to ask Fiona any questions, either from what she's just spoken to or what she shared in her written update. OK, we've got a question from Graham. I'll bring you in, Graham.
Good morning, and Fiona, it would be hard to imagine you joining the organisation at a more tumultuous time, both internally and externally. I'm sure you never imagined that it would be set, your first weeks would be set against some of the turmoil, both social and political, that there is. So you have our support, but we also know that there are huge pressures on a chief executive simply just to get squeezed into how things have always been done, and I appreciate your comment in the report about having to bring some maybe radical changes to what we do. So it's really just to say to us, safe on behalf of some of the board members, indeed all of the board members, I'm sure that you'll have our support, and we encourage you to not lose that radical edge. Take this as your invitation to keep pestering the board right from the word go. Thank you.
Thanks, Graham. Sure, Fiona doesn't need the encouragement. She's got her sights set on the radical change and the pestering, but I think that's fantastic, and I'm sure we absolutely share your sentiments in supporting Fiona. And indeed, if I can reflect, I've been lucky enough to be in some of the rooms with Fiona during some of these early and difficult conversations, and I know that a lot of our stakeholders and partners and communities have really welcomed Fiona's approach as she's come into, as you quite rightly described, Graham, a really difficult time. Okay, any other questions or comments for Fiona? Okay, nothing there. You've briefed us well, Fiona. We're up to speed. Thank you very much. So the board are being asked to note the update. We're happy to do that. Lovely. So I'm going to move us on now. Now, you'll notice that the agenda is in a slightly different order this month, but all my committee chairs have been briefed, so you should all be ready. What we're going to do is we're going to take the committee assurance report, so the minutes and a verbal update from my committee chairs at this point ahead of taking the IPQR. We're just going to try this out and see if that is helpful so that members can get a feel for what's been scrutinised already within the committee structures before we then go on to looking at the performance data in the round. So I'm going to invite committee chairs in turn to speak to the minutes that we have in our pack. We do have one which is a verbal, but other than that you'll find them all in your combined papers. So first of all, I have the Clinical Governance Committee, which took place on the 2nd of May, and I would like to invite Alistair to speak to this, please.
Yeah, thank you, Sarah. The minutes are attached at the end of your bundle of papers, but there's two things I want to draw to the committee asked me to draw attention to the board. The first one is the ongoing situation with NDAS. And we received an update on that, and that is now being discussed at the highest level between the council and NHS Highland with a view to finding solutions to address the matter. And the other matter related to condition of buildings that are presently being used for maternity services, and it was acknowledged in the report that the buildings are not where we would want them to be and present challenges to us. However, the services are doing very well managing those challenges and providing the level of services that they do. And this is an area that the committee is going to take regular updates on, and hence being mentioned to yourselves this morning. I'm quite happy to answer any questions that people might have on the papers, or allow the executive directors to come in if it's of a more technical or detailed nature.
Thank you, Alistair. That's really helpful. Okay, do members have any questions, either from what Alistair has just updated, or looking at the minutes from the Clinical Governance Committee? Does anybody want to raise anything, any questions, or add any comment? Karen, I'll bring you in, please.
Morning, thank you. Thank you, Alistair. I think as a representative member of the Argyll and Bute IGB, I feel I'm starting to become a little bit of a broken record when it comes to the awareness of the patient-related outcomes for members of the Argyll and Bute community who are going into Glasgow and Clyde, and I feel that's quite invisible, and I just wonder how that's being represented through the clinical governance and other committees. Particularly, I know that there's work underway around that, but I do believe when I read this, I don't see Argyll and Bute represented in the committee papers, and that might be just my lack of understanding, but I would appreciate if there's an opportunity to just discuss that a little further. Thank you.
Thanks, Karen. That's a helpful question. Alistair, do you want to come back on that?
Yeah, thank you for the question. Of course, the structure in Argyll and Bute allows them to have their own subcommittees that look into these areas in more depth, and I'm quite happy to direct Karen in the area so you can see the papers relating to that. For instance, at recent meetings, the Clinical Governance Committee has been taking assurance reports on things like the sexual health service within Argyll and Bute, and shortages in provision in that area and challenges surrounding that. But the detail of the clinical risk is dealt with by its own committee, which I think Graham might chair. Forgive me, Graham, if I got it wrong, but I think Graham might chair that. Thank you.
Well, Alistair, you stimulate lots of people want to come in now. So I'm just wondering, Karen, you maybe wanted to come back in on that to clarify. So if I bring Karen in, and then I'll bring in Graham and Fiona.
Yeah, thank you. And I'm actually on that committee, Alistair, so I'm aware of the information that's coming through. But I think it's a general point around the availability of information from Greater Glasgow and Clyde is, in my view, limited, and we really don't have, I believe, assurance from the experience of people, because we just don't get the detail at the moment. And I know that's something that Fiona and others are working on, but I think it's an important point to make, that this report that we see, I just feel that there's a missing part of the jigsaw puzzle, really, for the whole of NHS Highland. Thank you.
Thanks, Karen. And yeah, I'll bring Fiona in, because this is something that we've been discussing for some time. So Fiona, I'll bring you in with some update and context there, please.
Thank you, Chair. And I'll just pop my old hat back on momentarily, because it's with that hat on that I can probably answer this question, because as Karen has said, when I was Chief Officer in Argyll and Bute, one of my observations is that the experience of patients in Glasgow wasn't identifiable to us. We couldn't see that within the current systems. And what that appeared to relate to was really a facet of the service level agreement mechanism, in which the movement of patients between boards is seen, if you like, as an activity or a contractual financial arrangement. And that the understanding, I think, historically has been that the clinical governance of that patient having the treatment in Glasgow would be picked up by clinical and care governance within NHS Greater Glasgow and Clyde. I think in our modern world, we would probably want to hear more about user experience and about family or carer experience, and that existing mechanism doesn't allow that. So as I try to rebuild our relationship with Greater Glasgow and Clyde in my previous role, one of the areas that I highlighted needed greater consideration was the aspect of quality within the reporting, that it couldn't just be a discussion about activity and finance. Now, I think that's at its very early stages, and I've handed that over to Evan to continue to progress that conversation with Glasgow so that the information can feed into the Clinical and Care Governance Committee within the IJB. But I think we need to reflect that nationally that mechanism isn't replicated in other boards that utilise SLA arrangements, as I would understand it. So I do think it's something we need to work on, but we also probably need to feed that in across NHS Scotland, that mechanism isn't allowing the level of scrutiny and oversight of quality that we would want in an ideal world.
Thanks, Fiona. And before I bring Graham in, I would just echo that point that you made there about the national conversation. And certainly, as there have been conversations taking place nationally around how we might look to work in the future on a more regional kind of cross-border basis, as we're going to have to in order to deliver the services, particularly where we've got fragile services, dispersed populations, and we need to kind of work collectively across those borders. There have been conversations nationally about what does that look like in terms of accountability and scrutiny in the data and how that all flows. So I think you're right. I think we have a problem in terms of the data that we can see, but it is absolutely replicated nationally and is something that will need to be resolved if, as a whole NHS Scotland system, we are going to work effectively in that regional way. But I'll bring Graham in as well. Graham.
Yes, it's really just to add a point to what Karen has highlighted, and it's almost a total lack of understanding of the issue. I think in terms of the numbers, we're probably talking about 40% of the population of Argyll, and I say probably because no one really seems to know exactly what it is, and that's clearly a matter of concern when so many of our stakeholders simply have no access to some of the standards that we are taking for granted elsewhere. Thanks.
Okay, thanks. So to be continued. Thanks, Karen. Okay, I'm not seeing any other questions or comments there for... Oh no, sorry, that's not true. David.
Sorry, Chair, just to add to that, we recently had a sponsorship meeting with Scottish Government, and one of the subjects that we raised was around this very topic of working more nationally and regionally and having the infrastructure, particularly from a technical point of view and a reporting point of view, that would allow that to take place. And we did stress the importance of making sure that we had the required reporting and system access to allow us to do those things. So it is a topic that we have raised, so hopefully we will be able to see some progress along those lines.
Thanks, David. And I'm happy to continue to raise it in the forums that I'm part of nationally as we have those conversations more broadly, because I think you're right, Karen, it's really important and for us to be able to get that information and assurance. Okay, that was great. Thank you for that update, Alistair. I'll move us on now to, I think we've got two sets of minutes from the Finance, Resource and Performance Committee, 12th of April and 3rd of May, and I will invite Alex to speak to these, please.
Yeah, thanks very much, Sarah. Yeah, we had the two meetings, as you say, the 12th of April and the 3rd of May. The finance position was discussed and has greatly improved. So teams have done very, very well. I won't go to, this will be something that Elliot will talk about later on in the board meeting. But in essence, our financial position came in just under 30 million overspend, which was much better than had previously been quoted. The budget planning situation, there was a lot of discussion in that, and we'll hear more about that again later today, particularly in the choices that we are aware of and will be placed. And the Scottish Government has sent us a letter, and again that will be discussed in more detail. We had a long discussion about the pause in the capital spend, both in Caithness and in Lochaber, and again that's something that we'll keep an eye on as we move through through the year. Open to any questions on either sets of minutes.
Thanks, Alex. And as you said, we've got a substantive item later in the agenda where we'll be looking at this in detail as a board, but happy if members have got any questions or comments with regards to the FRP committee at this point. No? Okay. I suppose actually I would just like to say at this point and recognise that the committee have been working incredibly hard. We stepped, a while back we stepped up to monthly meetings, and obviously all of our committees work very, very hard. But just to recognise the additional work that FRP have been doing to complement the support that we've been getting from Scottish Government and as has been necessary. But I just wanted to recognise that because it has been fast and furious, and I think that needs to be recognised. Okay, right, I will move us on then. So there was a staff governance meeting just earlier this month, and we don't have the minutes not available yet, but I will invite the chair, Anne, to give us a verbal update from staff governance.
Thanks, Sarah, and good morning, everybody. As Sarah said, we met on the 7th of May with good attendance. I'm afraid that due to annual leave, it's not been possible to provide an agreed draft minutes, hence I'll be giving a slightly longer verbal report than I would otherwise be doing. So the committee considered assurance on a number of items at its meeting. The key matters which are not on your agenda specifically today included progress with our staff engagement plans, progress with our Speak Up action plan, including actions following our culture work pause and reflect, our draft health and wellbeing strategy, and the feedback from Scottish Government on our submission on staff governance standards monitoring for the last year. We didn't agree any matters for formal escalation to the board. However, there are a number of matters that I'd just like to draw your attention to. Our Chief Executive Officer included in her report a reference to the importance of our health and wellbeing strategy. So I won't repeat the remarks she made in her report, I'll just endorse them. There's also a number of our metrics appear in the IPQR, but I wanted to just focus specifically on the discussion around the time to fill metrics, which some of the eagle-eyed amongst you will have noticed has deteriorated over 2 committee cycles now. So we heard about the range of work that was already ongoing to improve our recruitment processes. However, whilst that may bring about some improvement, our Director of People and Culture also flagged up that there may be a need for some more fundamental change to the current hybrid model for recruitment, where responsibility is shared between team leads and managers and the recruitment team. So I think the committee were assured that there is a lot of work ongoing, but I think it's fair to say that if the decision is that the model needs to change to bring about sustained improvement and to get us more in line with some of the best in class boards on this point, then that may obviously take some time to actually agree and put in place. The narrative on a number of other metrics is in the later report on the agenda, so I won't go into that in any detail. But just to say that we are receiving appropriate updates on those which have been stubbornly going in the wrong direction or not improvement for some time. So I think the committee are content that pragmatic trajectories are being set on those metrics, and that accountability is being supported by regular data reporting to directorate teams for their individual action, and then to ourselves as a committee in due course. As part of the report on the work on the Speak Up action plan, it was drawn to our attention that the current contract for the Guardian service is due to come to an end in July this year. Discussions have been happening about what the future approach should be to these services, and the committee agreed to highlight to the board that it's likely that the staff side position is going to be that this service should be delivered in-house in future. Some of us will be well aware that contracting with an independent organisation to provide a confidential route for staff to raise concerns within the organisation was a key plank of our response to the Sturrock report. And with our original 3-year culture action plan having been completed and having refreshed our approach to a more business as usual approach to our culture work, it's clearly been considered appropriate to review whether the Guardian service option is continuing to be the best value option. Any firm proposal for change on this front will obviously have to come through staff governance and board after it's been through further partnership discussion. However, I think it was considered helpful perhaps to cite the board on this issue now, so that if there are concerns, this can be flagged up in the remaining work to be done. The committee members, several committee members, I think, emphasised during the discussion the importance of allowing time for full consultation with all stakeholders with an interest, particularly our operational managers. And if change is agreed, then making sure we're allowing sufficient time for any new arrangements to bed in. So it was acknowledged, I think, that that may require an extension to the current contract if there is to be change. Finish on a positive note, the feedback from Scottish Government on last year's staff governance standards monitoring submission recognised a number of areas of work that had gone well, and several of which were related to our culture work and staff engagement. So those are the matters I'd like to draw to your attention, and happy to take any questions.
Thanks, Anne. That's really helpful. And obviously the minute will be in front of us next time we meet to be ratified. But I think that's very helpful that Anne has given us a rundown of the work of the committee this month. Does anybody have any questions or comment following Anne's update? No? Okay, thank you very much, Anne. We have next on the list the Highland Health and Social Care Committee of the 8th of May, and I would like to invite Jerry to speak to this one, please.
Thank you, Sarah. I'll just briefly run through some of the key papers which were received by the committee on the 8th of May. We received a finance update from Elaine Ward, both on 23-24 and 24-25, but obviously I will defer to later discussions on this agenda because it's been a fairly fluid position, but the committee were brought up to speed on terms of the position as it relates to the partnership, and our thanks to our finance colleagues for being able to do that. We received an excellent paper, I think, on self-directed support, all the aspects of self-directed support. And I think one of the key things that was identified in the paper there was we view self-directed support as being one of those key enablers for making the changes we need to make in the provision of social care. But we probably have a need to look at our own systems and processes, because some of those are frankly getting in our way of actually making those changes. And we were pleased to hear from Ian that is getting taken forward. We also had the annual report from the Care Home Collaborative, which gave us an excellent update on the work and the pressures facing our care home sector. It covered multiple aspects of provision. We touched on sustainability of the sector, which we're always aware of, but also actually the excellent work which colleagues are doing out in that sector. I was asked, and if I can make this little plea, and I'm sure Helen will take this forward for us, the Care Home Collaborative continues to be supported on this non-recurring money which we get every year, which makes longer term planning difficult, as it does for so many services. But that's if we could just continue to raise that with Scottish Government, as I'm sure we do. I think it's worthwhile noting on the fees and charges the implementation of the £12 per hour for all care workers across the piece. I think I described it at the meeting. It's a start. It's not where we would like to be, but it's a start, and it's a significant upgrade from where we are. Moving on to the IPQR, I think the overall feeling at the board was that the IPQR, as it relates to health and social care, now has probably reached that point where we had discussion of whether it was static or whether it was stable and all that. So we're going to take forward a series of discussions on how we now need to develop the IPQR to actually inform and help our implementation of strategic changes that we need to be making. And I've got some time diaried with Lorraine Cowie and Pam, I think later this week or possibly next week, just to pick that up and kick that off. So I think that will be interesting. Pam Cremin in her Chief Officer's report gave us an update on the vaccination programme and the options appraisal exercise, which is probably now just about to commence in terms of engagement with the key stakeholders, and we agreed that would remain a standing agenda item through to implementation of whatever the revised delivery arrangements are in time for the winter of this year. And it was mentioned very briefly at the conclusion of the meeting, but Fiona has picked it up in her Chief Executive's report in terms of, I think this was 2 days, hence the expression of discontent on Sky. So it was picked up very briefly there, but it was brought to the committee's attention. So we were aware of that. And probably just to finish off, I noted that it was the last meeting of 2 of our lay members, Michelle Stevenson and Wendy Smith, and the committee expressed their thanks for their long-term contributions to the work of the committee, and we've begun the recruitment process with Ruth in terms of replacing us. So happy to pick up any other issues, Sarah. Thank you.
Thanks, Jay. That was a really helpful update, actually. Thank you for giving us that detail. Okay, does anybody have any questions or comments to add after Jerry's update? No, okay, fantastic. So I will move us on now to audit, which took place on the 21st of May, and I will invite Gaynor to speak to this one, please.
Thanks, Chair. So as of the Audit Committee meeting last week, we've completed 9 audits and deferred 2 till 24-25, and we have 2 outstanding audits, and we've added an additional meeting on the 18th of June to look at those, and those are complex care packages and adult social care services. In terms of our outstanding management actions, so to date 32 have been completed and agreed with internal audit, and 25 are on track or being progressed with a revised completion date. In terms of those 25, I called in the audit sponsors for verbal updates in relation to those outstanding actions and their proposed revised completion dates. And the discussion that we had on each of those audits are in the committee meeting minutes. We have one action that, as of last week, was not yet due. So things are progressing well. There still are a number of outstanding audit actions, but they are now being progressed with revised completion dates, and we'll keep doing those, getting those verbal updates to committee as and when is needed. I think committee were happy with the dates that had been proposed and the reasons for those dates having to be changed. Yeah, and I don't think I've got anything else to say other than the note of the meeting is there. If there are any questions, I'm happy to take those. Thank you.
That's great. Thanks for that update, Gaynor. I think quite a few of us were at the audit committee as well, so probably were in those discussions, but that's a really helpful update. Thank you. Does anybody have any questions or comments following Gaynor's update? No, okay. And then last but definitely not least, we have the Argyll and Bute IJB, which is always kind of 2 months behind in this reporting cycle, but I'll hand over to Graham to give us any updates from that, or in fact anything live as well. Thanks, Graham.
Yes, indeed. And our next meeting is tomorrow. So all the news, etc., will be hot off the press then. But it'll be another 2 months before. Oh no, it will be. Maybe next month you'll get to hear about it a bit earlier, because I'm sure you all sit in tenterhooks waiting on news from Argyll and Bute. A big change in that our partnership with Argyll and Bute Council underwent a fundamental change with the change of political leadership. So we're starting tomorrow. We have our first face-to-face meeting with certainly from our point of view as NHS board members. We'll meet the councillors allocated to do it in person. So that gives us a good opportunity to get a fresh start on and keeping things going. At our last meeting, it was just at the end of the financial year, so we had brought in, we were looking at bringing in a balanced budget, which was good, and in looking at that, we were aware of some of the fundamental challenges that really underline the service delivery, maybe not too different from the rest of the board region, but certainly in the more remote and rural areas, the staffing challenges remain huge. And Anne mentioned earlier that I think she was quoting Gareth saying that we might need to look more fundamentally at how we recruit. And I think that's certainly the case. We maybe need to be learning more lessons about what works. But we also have to recognise that even if we had the best systems in the world, there are some fundamental staff shortages that are really beyond our ability to tackle. So we always have a kind of mixed feeling when we're looking at the budget, and you're seeing some things are coming in indeed on budget, but knowing that that's because we're actually short in some areas of staffing, and these look like long-term gaps. So a big issue for us, and one that we'll be continuing to address as we move forward. But that's all from Argyll and Bute at the moment.
Thank you, Graham. I was so excited that I pressed my mute button twice there. I always enjoy hearing the updates. It's nice to hear how it's going. But that's good. Thank you. Does anybody have any questions or comments for Graham following his update? And as you said, Graham, it's all going to happen tomorrow. We wait with bated breath for further update. Right, lovely, thank you. Okay, so we were being, sorry, one moment, I'm of course looking at the wrong screen now. So we're being asked to confirm that adequate assurance has been provided from our board governance committees and note those minutes and updates from our chairs. Are we happy with that? Lovely. Okay, and that moves us now on, so complementing that, moves us into our integrated performance and quality report, where we will see the performance of the organisation in the whole. And I'm going to hand over to David to coordinate this for me. Thank you, David.
Thanks, Sarah. Good morning, everyone. You'll find in your combined papers the IPQR for the May board report from pages 36 through to 88. From the observant amongst you, you'll find that's quite an extensive section as you've read through the papers, and maybe for the keen gardeners at this time of year, pruning might be required. I think we may have to do that with the IPQR a little, and maybe sequence some of the reports that may be of interest to colleagues. The regular report is in pages 36 to 77, and additionally this time we also have an excerpt from the Integration Performance Management Report from Argyll and Bute in pages 78 to 88. As you'll remember, these reports and their constituent parts go through our subcommittees of the board. That's clinical and care governance, staff governance, and finance resource and performance. and they have been discussed, and some of those items have been mentioned already in those introduction remarks in the previous item. The IPQR contains some patient feedback, and we look to rotate the areas where we're getting patient feedback. We don't have a fully extensive reporting mechanism for that, but where we do have information, then that is reported. Also, again, where we've got information around benchmarking, we're showing the benchmarking in relation to where we are against the rest of Scotland for reference. I would mention at this point that at this time of year, we find that the target setting will start to change as the ADP is approved. I'll not go into that right at this point in time. That's an item later for discussion, but to mention that that will take place in due course, but the targets that are mentioned here relate to the year gone past. As far as the report itself is concerned, then it follows a number of different themes going through it. Just to pick out a few with regard to prevention, there's a report around our COVID vaccination. I think we recognised before that the uptake of COVID vaccinations across the country is much lower, and you'll see that our comparator that we've stated in the report is against similar type of reports, but equally the national standard is actually below where these numbers are. But these are still important elements for us to review. Good news around drug and alcohol waiting times, so we're seeing continual improvement in terms of our performance there. We're also seeing performance improving in our psychological therapies. We've had sustained performance over the last 5 months, and colleagues will remember that we were escalated for this item through Scottish Government, and we'll be approaching them in terms of de-escalation in due course, and we're in dialogue with them as to how that goes about and whether they will accept where we are and our sustained improvement. CAMS is the other area of escalation, and while we've seen the overall waiting list come down, as well as the long waits come down, the performance against the 18-week target is still relatively static, so that's still looking for improvement, and indeed that will be subject to our ADP submissions going into this coming year. Just to point out from the cancer reporting, the detailed report is accurate. However, in the executive summary, a couple of comments that should have been updated that were missed. The 31-day performance has actually now improved for 2 months in a row, not 1 month. I think that was all comments. And in 62-day performance, then actually, although we had several months where we had low performance, this last report has shown an increase to about 79.3%, which was similar to how we were performing earlier in the year. Patient feedback in one area is around endoscopy. The patient feedback in these areas is generally very low. We would have tried to put more balanced feedback between positive and negative, but there are some times where we see positive feedback given, but that tends to be on an even lower sense than the feedback given. But just to say, even though the complaint rate is low, the team are keen to hear the feedback from patients in order to improve, and you'll see some of the comments and responses in relation to that. It's quite an extended section on clinical and care governance. It covers how we reference reports against the Scottish Public Service Ombudsman, or SPSO, the complaints I mentioned there, as well as SERs, and there's also a focus on falls and infection control. And then finally, around staff governance, Anne has mentioned the vacancy time to fill, and that was discussed at length within our staff governance committee, and also to recognise that our improvement around mandatory e-learning continues, and it's had a steady increase over these last several months, which is good news. So that's the end of my comments for the moment. I'm happy to open up to questions, and I'm sure my fellow colleagues will be ready to answer. Thank you. So Susan, I'll come to you. Congratulations, you beat Alistair to the punch today. He's normally first, so but I made a joking comment the last time, and I hope I haven't put you off, Alistair. I'm sure not. But Susan, I'll come to you first.
Thank you very much, and thank you for the report. And I acknowledge it. There's a lot of information there, but I think as a non-executive taking in this information, I like to have it all there, and then I can dip in and out of it rather than have it selected for me beforehand. But that's maybe just my own preference. I've got a general point and then a more specific one. There was a general point about the smoking cessation, and it prompted me to think, how do we frame this against what we know about national trends? Because here we're saying we've got this target for this many people. Are we reaching more of the people as numbers smoking drop, or are we meeting fewer of the people as numbers smoking increase? There was just a bit of, where does this fit within some national picture about what's happening with people smoking in the population? And I think particularly with some of our public health things, I don't know whether there's any way to put some, a couple of words in about that, because we might think we're doing very well to keep steady state with this number of interventions, but is it making a smaller or a bigger impact on the whole picture? Was something that could relate to more of our areas as well, I think. And my other point was about CAMHS, and you mentioned that. You said it's escalating, you said it's going to be reflected in the annual delivery plan, but I noted the point it said about we need more staff, we're understaffed, and I wondered if the issue of staffing was something that is already planned to be addressed. Is that part of that delivery plan? Thank you.
Thanks, Susan. I'll come to Tim first for the smoking cessation element of that, and then I'll come to Catherine with regard to CAMHS, if I may. Tim?
Yeah, thank you. I think that's a very apposite question. And I think, as the IPQR shows in terms of smoking cessation, that I don't think we can certainly say we're doing particularly well, although there are and there's a bit of a lag with the data, and we've got lots of interventions in place which will improve that. With reference to our overall performance, with this and other public health measures, it's always a little bit tricky, because what we tend to use are process measures rather than outcome measures, and it would be better if we were looking at the percentage of people who smoke in the population, or children who smoke, or even children who vape, if we can get that information, and look at bringing that down. So we're always using those process measures which have a degree of inadequacy in them. I think our performance is reasonable compared with other places. The particular indicator in the IPQR, I think, is important, because it's subject to quite a lot of variation because the numbers are small, but it's one of the very few indicators that actually focuses on health inequalities and focuses on people in more deprived areas. So it's a good indicator in that regard. But like many tobacco control and smoking cessation indicators, it has an overall level of inadequacy because it's just around quitters. So I think it's something that we need to develop, as in the particular case of tobacco control, we look across tobacco control and see how we can improve that. And this indicator is only one small part of that. It's just difficult to find better ones. There is currently a national review going on of smoking cessation and tobacco control indicators. So I think in due course, probably early next year, we'll be able to have put a better input into the IPQR and into overall performance management about how we look at tobacco control. So there are some interesting thoughts around what could be included. For example, it may be possible to include an indicator on quitting and smoking cessation within hospitals, which I think, particularly in our local context, would be of great interest. So I think there's a lot more that we could do. I think it is good to include the inequalities element in that, but the more we can focus on stuff really related to meaningful outcomes, the better.
Thanks, Tim, and hopefully that's been helpful. Susan, Catherine, can I come to you with regard to the CAMS question, please, and around resources?
Yeah, sure. And that relates specifically to the allocation of the mental health outcomes framework. And there has been a slight reduction in terms of the investment from government in terms of mental health outcomes. And that comes to us and needs to be sort of considered and divvied up across, obviously, psychology, CAMS, mental health, et al. So those considerations are currently going on at exec level. And once the outcome of those deliberations are clear, then we can be more specific in terms of the trajectories. And that applies across both North Highland and Argyll and Bute.
Thanks, Catherine. Alex, can I come to you, please?
Thanks, David. Yeah, once again, I like the report. I think there's an awful lot of information there. As you said at the start about trimming, David, I wouldn't. I like this. I think it's good. Like Susan, you can dip in, you can dip out, you can take from it what you want. I really like the bit about I know in some cases they don't look very good, but where we are against the other boards, 5th, 6th, 4th, whatever. I think that gives us a feel for how we're doing, particularly as we look at it over time. A couple of specific things. One for Gareth, when we actually look at the amount of mandatory training, it's basically static. But the bit that really worries me on that page is the fact that I think we're only at 25% of the appraisals. I don't understand why that's as low as that. Now, maybe just a timing thing within the year, but that doesn't look particularly good. The other question on a delayed discharge for Pam is that if you look at it over a long period of time, this year we're not actually too bad. The increase from March 23 to March 24 is minimal. It's probably in the noise. But going further back, do we understand why, in essence, we're about 50% worse than we were 2 years ago and almost 100% worse than we were 3 years ago? That bit I don't quite get. I don't get a sense of that coming through in either the narrative or the discussion. Thanks for that.
Thanks, Alex. Thanks for your comments around the report. Feedback's always welcome. Benchmarking where we can, not always has benchmarking data available. So if it is available, you can be assured we're trying to put that onto the report just so that you have that reference point. And we try to, again, put the national picture as well as, in some cases, just some focused groups that might be similar boards to yourselves. With regard to the staff lab governance questions, Gareth, can I come to you to talk to those, please?
Yeah, so in relation to probably both metrics mentioned, I'll speak on behalf of colleagues. This is something shared as a responsibility across all of our executive team. So in terms of the mandatory training, there's a short life working group that was set up tail end of last year, really to look at any barriers to completing mandatory e-learning, and that's progressed with the production of new reports and a number of actions taken forwards to ensure people can access the training effectively. So I think this needs to come back to how we report and look at this through our performance management for staff governance across the organisation, and responsibility for all of us as exec leads for our areas to try and drive that up. So there are reports available now which are improving that visibility of where improvements are required. So it still remains a focus. And I think we need to look at how we then provide maybe more detail behind the aggregated data at an organisational level to see where we need to focus our effort as an executive team. So that's something I want to pick up as a conversation with exec colleagues. So we've got that at a suitably drilled down level in the right forums to discuss. Similarly, appraisals is not where it should be, and that's a responsibility of all of us. One of the papers we took through staff governance, the Area Partnership Forum staff governance, was a plan which is going to be run through this year, which is to focus on all managers having their PDRs, appraisals completed this year, and that is currently being prepared in terms of the materials to make sure we take a refreshed approach to that with additional information around what the focus should be for appraising managers. So the managers of managers, looking at their leadership capabilities and what they need to focus on. And part of that will be looking at how are they doing in relation to managing their appraisals, managing their mandatory training, their responsibilities. So that was included in the proposal that was taken through Staff Governance Committee to provide assurance that we're looking at it in a different way. And that the terminology I suppose I'm using is, if we focus on the managers, that should bootstrap everything else up, so that they're focusing on their direct reports, and then that will ripple down through the organisation. So that's a pragmatic way of trying to really focus the effort, but it is going to require a degree of concentration over the next year to really drive that up.
Thanks, Gareth. And before I come to Pam, just a couple of things for me on those. I think in the metrics, it helpfully extrapolates the e-learning modules versus the practical training and the classroom-based training. As I say, the e-learning module training is improving steadily. I think the practical training, what I've seen recently is a review of the content and duration of that training with the view to improve attendance, because obviously teams under pressure from a staffing point of view, releasing staff then for training, it gets into that trade-off. So if we can make it practically easier, then we hope that the uptake will improve there also. Pam, can I come to you with regard to delayed discharges, please? Thanks.
Yes, of course. So in answer to the point raised by Alex around the period of time that we see the trend for the delayed discharges, you'll recall that this will be in direct correlation to the reduction in the care home beds within the independent care sector over that period of time. So we've not put that legacy information onto the IPQR, but maybe we need to have a think about that when we review the Health and Social Care IPQR for the Health and Social Care Committee. So that might be an area that we want to look at in terms of understanding our trend analysis and applying the interventions that we're currently doing. So there previously had been a focus on the direct correlation between the rise in delayed discharges and the reduction in independent care home sector beds. However, we now have a more focused whole system delayed discharge action plan that looks at our overall charter and driver diagram around urgent and unscheduled care, when we are trying to address the issues across the whole system and really focusing in on our urgent response and our home is best, so that we get people home to their own homes, and we have work streams around care at home and where we can maximise our efficiencies and apply all of our resources equitably across our system. So I would say that that's a legacy part of that trend of what you're seeing. Thank you.
Thanks, Pam. Muriel, can I come to you for your question, please?
Thank you, and thank you for the report and the amount of data that it gives us. One quick question is there was a mention of the reduction or the lower uptake of COVID vaccines. NHS Highland are very good with their communications daily and their briefings daily. Should we include in that the number of COVID cases? Because I'm sitting here just now and I know 6 colleagues across the board that have got COVID just now. So that must have an operational impact as well. And I think it's important personally that the public are aware that COVID is still running around in our society and possibly impacting some of the delivery that we are able to achieve.
Thanks, Muriel. I'll invite Tim to talk to this one, but recognising that the testing process has ceased in its previous form. But Tim.
Yeah, I mean, I think that's the most important point, that testing, community testing has stopped. There is still some testing and testing where, for example, people coming into hospital. There are some changes that are forthcoming around further reduction in testing. So we know that COVID is still present in the community, and it's important that we make people aware of that. But with regard actually the absolute numbers, we can't do that because we haven't got the numbers. All we've got are some numbers around testing with people with people who either maybe have tested themselves or still have valid kits. I mean, I for example had to dispose quite recently of the kits I had at home because they're out of date. So I wouldn't know if I became ill with COVID-like symptoms unless I was ill enough to go into hospital, whether I would have COVID. So I think it's right that we continue to stress the importance that COVID is still around, but in terms of numbers, we don't know. There is scope, I would say, for reintroducing measures, testing, looking at variants, should they arise. But at the moment, we don't have the facility to be putting numbers out. So I think it's a moot point how useful it would be. But even if we felt it would be useful, we couldn't do that because we haven't got the numbers.
Thanks, Tim. Gareth, did you want to come in on that point? I'd imagine related to staff.
Yeah, it's just to be exactly the point Tim's made. We don't. It's because of the changes to guidance in terms of the recording in relation to staff sickness absence. It's no longer captured as a separate item within sickness absence, so we wouldn't be able to track it because of the reasons for not testing for it.
Thanks. Alistair, let me come to you, and of course your questions are always welcome, Alistair, despite my humour, but go ahead.
No problem. Just looking at the executive summary and trying to understand it and just turning it around, what that's telling us on that sheet that only a third of our performance measures are actually on target, or where they should be. This question of, how does that compare? It would be useful to know how that benchmarks with other areas, because we see on the individual sheets what our performance is benchmarked with other health boards, but we don't get that overall cumulative impact or collective impact as to what it is. It might be useful if there's some thought could go into around that, because obviously when you look at the summary sheet, there's an awful lot of red and amber on it compared to green. Some of the areas we've already discussed. I suppose just looking at delayed discharges, I don't know if we can do it, but it'd be useful to attribute some sort of financial value to the lost bed days, so we can just actually see, or the opportunity cost of the lost bed days, so we can get some thinking or performance measure around that. And with cancer, which is something that I usually speak on, trying to take assurance from that is difficult, because if you look at the graphs, the variation between months is quite significant. If you were to look for the 31-day target at January 24, compare it to February and March, there's quite a large variance. So I suppose the question, Catherine, what can we do to better predict this? What happened in February and March 24 that was different, that actually started to return it back to where we want to be, which is great news that it is back there. And I suppose the same applies for the 62-day wait, that we're not seeing any consistency across the months. It's quite a big variation from month to month, with quite big spikes, and then there's a little bit of a plateau, and then it's off again. So it's just trying to get some understanding around when we can actually take assurance that things are going to sustain the service performance we want to see. Thank you.
Thanks, Alistair. Good questions. I think with regard to the cost of delayed discharges, we have looked at that previously in terms of how to do that. There's 2 or 3 different ways to do it. Probably nominal hospital costing is probably the worst way to do it. But what we have been looking at it is what the variable cost on the hospital is and the hospitals are by having more people in them than there should be. So that's one aspect, recognising too that there's a cost element if indeed these patients were in the community, then there's additional financial burden that would be showing within adult social care. So there are different ways that we can do it, and we're happy to look at that for future reports so that it's indicative and maybe give different angles so that we can form a view around that. I will come to Catherine with regard to cancer, but just to mention, which and I hope I'm not stealing your thunder, Catherine, but two things. That the cancer 31 and 62 day element actually covers a number of different clinical streams, although they all fall under the category of cancer. Also, the number of patients that we see is relatively small, and 1 or 2 patients suddenly skew the data. So in terms of how we try to represent it, we try to show that with control charts, and this is where we're expecting variation. And I suppose the question is, the more tight the control chart, the smaller the variation, which is what we would like to have. I think the last aspect to that is that a lot of these services are single clinician dependent, and when we see variation in those clinical loads or indeed that clinical capacity, it has an adverse effect which is immediately seen in the charts. But Catherine, sorry, if you want to add to that, please do, or correct for that matter.
Yeah, not a huge amount to add, David, to what you've described there. I think it's a very good question to ask, Alistair, and we need to be able to project forward, I think is your point, so we can take evasive action in advance rather than looking at past performance. So there's a level of sophistication that we would need to get into. I think because we're getting into a more stable position, we're in a better position to do that. There are hundreds of variables that affect cancer performance, as I'm sure you can understand, across all of the various services. So it's about how we do that. Sometimes our cancer performance can be affected by us actually treating people that have already breached the cancer target. And if we are treating a number of those and clearing backlogs of patients, then that also impacts our cancer performance. And I'm sure, Alistair, you'll understand how that is all calculated. So I think we could predict that perhaps we're going to have a poor performance, but actually that's a necessary evil, if you like, in terms of improving performance overall and getting out of that position. So there's no straight answer, I'm afraid, to it, but certainly happy to go away and we can look at trying to bring into the reports a bit of a prediction of what we think is going to be happening, which I think would respond to the question you've asked us.
Thanks, Alistair. Thanks, Catherine. Okay, Karen, can I come to you?
Thank you, and thanks, David and colleagues, for the comprehensive report. I echo others' feedback that I think the more detailed, to me, the better. We can then take out the bits that particularly interest us. I've got two comments, really. The first is back to the benchmarking topic, and I just wonder if it may focus our minds if we also highlight Greater Glasgow and Clyde, given that 40% of Argyll and Bute residents will be experiencing their services through that SLA or contract or whatever commission that we call it, and it just may help to remind us of the experiences that they may be receiving, and whether that's something that we could just draw a line around as well as ourselves, or as well as NHS Highland in the graph. And then the second point is around appraisal rates, and I appreciate the pragmatic approach, and I understand the rationale behind that. I do wonder if the improvements that are being made means that perhaps staff are waiting for a change before they start doing appraisals. Maybe that just affects behaviour a little. But I would appreciate more detail on the staff groups, because 25% of the whole of our employed staff is one thing, but I think to see the detail in different staff groups, because if our registered professionals are in the 25% layer, then I think that's an area that we would need to have further analysis around, and perhaps investigation as to why that's happening, because those registered professionals should be have more responsibility around that area. And I think that is something that it would be better to see more information, more detail around. Thank you.
Thanks, Karen. I'll come back to Gareth in a moment. As far as the benchmarking question that you raised, I think that's a really valid point to make, and we most certainly can look at putting Greater Glasgow and Clyde on those reference points when that's available, so that it's transparent from that point of view. Absolutely. What we won't be able to do necessarily is to single out Argyll and Bute patients in relation to that, but nonetheless it's a useful context, so we can certainly do that. Gareth, any more you would like to add around appraisal rates that Karen has raised?
I think it's probably something that we worth taking to the Staff Governance Committee for a bit more discussion, but I think it's worth highlighting that there's a difference between the revalidation processes, and my clinical colleagues and care colleagues might want to come in on this one. There's separate processes for professional revalidation, medical appraisal, etc. So the appraisal rates we talk about here are the all staff. So I think it may not be helpful to separate it out. It may be useful to look at it a different way.
Okay. Thank you. Sarah, can I come to you?
Thanks. I don't know if Evan was wanting to come in on Karen's point before I jump in. I don't know if he had a...
Apologies, Evan.
I wasn't happy to, and really grateful, Karen, for that question. Just to confirm, that is something we're working on with GGNC colleagues. It's absolutely right that we need visibility of the sort of experience of our patients living in Argyll and Bute through that system. So that is under active discussion.
Okay, Sarah, it's unusual for me to be giving you permission to speak, but carry on.
And I quite like novelty. Okay, thank you. So first of all, I just wanted to congratulate the staff that have been working on those sustained improvements around psychological therapies. I think we can't underestimate how difficult it must be to sustain, let alone improve a service in what is undoubtedly a very challenged and pressured system. So I think that is worth recognising, and a big thank you to all the staff that have been working on that. A couple of questions. So I know we have kind of touched on it here and there, and it will have been scrutinised in at least 2, if not 3 of our committees. But I wondered if somebody could just say a little bit more for me around where we are exactly with that options appraisal work on the delivery of vaccines. Just, I know that it's live and it's ongoing, but if I could just understand exactly where we are with our options appraisals, and maybe if we have kind of timescales around that piece of work, because obviously that's going to be really critical in terms of how well we can deliver those vaccines going forward, and doing that in an improved way. And the other bit that I just wanted to touch on from a sort of a data understanding of the data a little bit better, I can see from the graphs that there were 2 that sort of stood out to me, both the A&E 4-hour target, those sort of data points taking a bit of a downward slope at the end there, and also the outpatients seeing an overall sort of downward. And I just wondered if Catherine maybe could say a little bit about those 2. Obviously, I understand that our emergency department performance in some ways is kind of an indicator for how pressured the rest of the system is. But I just wondered if there was anything that we needed to understand with regards to both of those trajectories. Thanks.
Thanks, Sarah. I'll maybe come to Tim in the first instance, and then maybe Pam might want to supplement anything Tim would be saying with regard to vaccines before I come to Catherine.
Thank you. Yeah, I mean, we have, as has been witnessed in a variety of ways, been challenged and found some of the vaccine delivery quite difficult, and the rates of vaccine delivery and the timeliness of vaccine delivery hasn't been what we would have wanted. Work has been going on within Highland HSCP for quite some time to look at what options would be best for delivery, and of course we're aware of the challenges, particularly in remote and rural places, and the comparison of how things have been delivered with general practice and current board delivery. We see a potential for more flexibility and have over recent weeks from Scottish Government in terms of flexibility of delivery, and we're looking to see how we can use that to improve the service and to provide a more efficient and effective service. So things have changed over the last few weeks, and we're working closely with Scottish Government, both in terms of the escalation that we're in from a performance point of view, and more generally, but also we're working closely with Public Health Scotland, and we have for a little while now, and Public Health Scotland are working with us at the moment. I might actually have to leave the board early to talk to somebody from Public Health Scotland around one of these things, and they're helping us with a peer review process in a couple of weeks' time in order to look at models and how we can best deliver. So things have been a bit slow, but we're seeing a greater degree of flexibility, and we're hoping that we can move quite quickly to a system that will get a more effective service.
Thanks, Tim. I suppose in terms of timing, we'll probably be able to provide an update, I would suggest, at the next board meeting. Pam, do you want to come in and add anything to what Tim was saying?
Yes, just to confirm that there has been wide engagement with the staff teams, particularly the teams who deliver the vaccinations, and we have got our options appraisals ready, around all the different alignments and where we're delivering well, etc. So we have a meeting on Friday just in terms of taking forward the formal process of looking at the options that are being presented more widely, and that will include engagement with general practice and across the districts, etc. And we are aiming to have the different options in place by the start of the adult programme in the autumn time. So we'll be actively working and implementing incrementally over the summer, and the approach that we're taking is where we understand that we have the staff in place, that we have the facilities in place, that we're delivering vaccines well, we'll move to early alignment. And of course we're having that parallel discussion with primary care colleagues and remote and rural areas and districts around our alignment options. So we're working on that at pace, and our launch is on Friday. Thank you.
Thanks, Pam, that's helpful. Alex, can I come back to you?
Yeah, thanks, David. Yeah, a couple of things. One, I should have asked when I was on the last time, but the other one was, the first one is about the benchmarking bit, and it may be a bit obvious, but I'm going to ask the question anyway. We've got data there which shows us which are the best performing boards. Are we talking to these boards to find out what they're doing differently to us in terms of the performance? So, for example, one of the things, we're 11th and one's the 14th. So any of the boards above us, we should be saying, well, what are you doing that could help us? Maybe that's happening, I don't know. And then the other question, which is on a specific, is for Louise on the number of hospital inpatient falls, which is getting progressively worse. And actually, in terms of inpatient falls of harm, really starting to ramp up. So it's something that, you know, can we understand the why? I mean, I know it says things about surge beds, etc., but that's a serious increase, particularly in people that are getting hurt when they're falling either in hospital or in one of our care settings. Thanks.
Yeah, thanks. I think in the benchmarking part, I think there's a number of touch points that many of the services have, because there's not only the formal way that we report benchmarking in the board papers, but recognising that there are actually a number of forums at specialty level where clinical professionals would meet together with other boards and be able to learn that way, as well as planning forums and various other things where the details of those are discussed. I think it's always a useful thing to make sure that we don't try to invent new solutions to something that somebody else already got. So it's an ongoing challenge with us to make sure that we are leveraging everything that we can that others are doing. So, but it's a very good question to ask. Louise, can I come to you with regard to the inpatient falls, please?
Yeah, absolutely. And indeed, Alex, I asked the same questions when I saw the information and the data, because clearly it is concerning. And previously we'd reported that the implementation of the new care plan seemed to have had a positive impact in that the falls were sustainably reducing, we thought, but clearly things have changed, unfortunately. And certainly when I asked the question of those directly involved, the message was that there weren't any obvious and clear indicators other than, as it says there, that we've got a lot of complexity in our wards, and we've got a lot of people that ideally are in delay that should be in a different and suitable environment and aren't, and the wards are having to manage having that type of patient population alongside people that have got more acute needs and having to manage both in the same setting. And certainly when we look at the data, there are often certain people that are falling repeatedly because of that, and best will in the world putting in plans, it's still tricky, but clearly we're looking at that in all of our individual settings, both in acute and community. It's not something we're just accepting that's how it is, and the work we're trying to do is very much look at those individualised plans for each of those people that are in a more vulnerable situation. And certainly some of the work that we've had to do by necessity because of the fire situation, where we've cohorted a number of people that have that more delayed discharge need, because they're waiting to be somewhere that they should be, as opposed to where they are at the moment. That might actually have a knock-on helpful effect because the staff are working with a more similar patient group. But again, it's early days to understand whether that's going to make a difference. And for example, in Argyll and Bute, we had a good spell, but we've had a bit of an uplift there too. So again, it's looking at each of our individual sites and seeing what else we can do.
Thanks, Louise, and thanks, Alex, for your question. Sorry, Catherine, I've missed your contribution. You've obviously wanted to come in at some point. I failed to notice your hand.
That's okay. It's just in response to Sarah's questions around ED performance and outpatients. So ED performance, Sarah, where we have been under continued pressure, particularly around our front door and those that need admitting into the hospital under a very, very pressured system. Rigmore has continued to see some significant challenges in that respect. And although we've been working hard to turn around ambulances very, very quickly, we're seeing increasing numbers of conveyances as well coming to the front door of the hospital. The other thing that is underlying that performance is the performance in Caithness. We've seen reduced performance in Caithness with a lot of pressure through the emergency department, which is the receiving area for the hospital in Caithness. And again, high numbers of patients in delay which has led to a number of patients that have had to be actually treated within the ED within Caithness, where they're not able to be moved into the hospital. So I think it's that increased pressure across the system and a general capacity in terms of our ED performance. And we are continuing to work with the Scottish Ambulance Service and obviously across system-wide to look at what we can do, and obviously PAMS and the Health and Social Care Partnerships action plan is absolutely critical for us to unlock that flow. When we do get the flow, we see our ED performance start to respond in the right direction. In terms of the outpatient side of things, that's very much in relation to capacity and finance. And recently the government has announced an amount of finance to be available to support additional activity. We've put some bids in that, and has been noted earlier in the meeting, and I think in the SBAR that supports the IPQR, we will bring back trajectories relating to that, which hopefully will start to recover some of that. We're running an outpatient workshop tomorrow and looking at any new pathways that we can bring to bear. Can we do more with our virtual capacity? Again, we have done well with that in the past, but is there anything further we can do in terms of that? And what can we do differently to stop adding patients to our outpatient waiting list? And how can we reduce the number of patients that are coming back repeatedly to increase capacity as well? So there's a number of actions that we're taking to try and improve that performance for outpatients. Thanks.
Thanks, Catherine, and apologies, Sarah, we missed the last part of your questions, but we got there in the end. Thank you to Catherine for capturing that. Okay, thank you all for your questions, colleagues. I mean, I would always say if there are other things that occur to you that you've not had the chance to ask this morning, or as you're seeing the reports, please don't hesitate to reach out to any of us, the executive team, and we'll be happy to support you in gaining information for you or answering your queries. But with that, I will hand back to the chair. Thank you.
Thanks, David. And of course, as we hinted at earlier on, all of this is scrutinised in more detail at our committees, which obviously will all be part of our different committees. But I would also suggest if members want to sit in on other committees to observe, and that can be a really good opportunity to see how something is being scrutinised in detail. And indeed, I know I'm going to volunteer my committee chairs here as well, but I know that my committee chairs are always happy to speak to other board members if they want to understand the work of each committee in a little bit more detail. So that's an option, and I think it's helpful that we can support each other in the wider scrutiny piece. So we are being asked to consider the level of performance across the system. You will note that the proposed level of assurance is limited. Now, obviously, it's quite tricky to pin one assurance level on something quite so complex, which conveys areas of positive performance and areas where we need to improve. So it's a little bit tricky to pin just one assurance level on something as big as the IPQR, but we are proposing limited assurance, I suppose, just to reflect the scale of the challenge and the pressure that the system is under at the moment. But that doesn't take away from the good work that is happening as well. So that is what is in front of us. Are board members happy with that? Yep. Okay, great. So we're a little bit ahead of schedule, but I think we should take a break now before we get into finance. I certainly require a coffee before we do the finance paper. So I'm going to suggest let's take about 15 minutes. So see you back here in 15 minutes. Have a stretch.